right. Great. So I've got my screen up. Hopefully you can see that. And then, yeah, if you ever lose the screen or anything, just holler at me. So yeah, I'm Megan Shaughnessy. I'm one of the infectious disease doctors here at HCMC. And I'm the medical director of our International Travel Medicine Clinic. And then I'm also the director of the Global Health Pathway for our internal medicine residents here. And I'm global health faculty at the U, and I work pretty closely with their global health program too. So I do a lot of education about travel medicine, in part because we have a lot of patients that come to us and get sent to us from other places. And I know that travel medicine can be a really tricky thing to do when it's kind of embedded in primary care. And so what I'm going to talk about today, if I can get my slides to advance, there we go. So I'm just going to go over some background on travel medicine. I'll talk a little bit about what we have available at Hennepin. And I'm happy to pass on information about how to get in touch with us, how we can help, and how you can get patients to us as needed. And then what I'm mostly going to focus on is the pre-travel consultation. This is a lecture that I've given before. That's kind of a longer lecture that does have some post-travel concerns in it. And my guess is, especially since we're getting a bit of a late start, since I had a very busy travel clinic this morning, we probably won't really get into that much, but I'll point out just a couple things. So I'm just going to go through my slides, and it's a little strange, of course, because, Zoom lectures are weird to begin with, but then I can't see anybody. So I sort of feel like I'm in a room talking to myself. So feel free. I don't have it up where I can see the chat easily, but feel free to stop me, get my attention if you have questions sort of as I go along. And this is the first time I've given a travel medicine talk since COVID. So obviously that's changed things a little bit, and we'll talk about that too. Prior to COVID, international travel was getting more and more popular, with even more people traveling than ever before. 1.2 billion travelers in 2015. And a lot of the travel is changing over time. So people are traveling more to developing regions. And then the reason for travel is also changing, where certainly tourism is still the most popular reason to travel, but the proportion or the types of travelers we're seeing increase overall is people who are visiting friends and relatives. And I'll get back to talk a little bit about that. And then medical tourism, I'm not really going to go into that today, but that's also an increasing problem that we'll see, and we'll highlight a little bit of what some of the issues there are. So even though a lot of people are traveling, not a lot of people go to a medical provider, only about 44%. And of that, it's a smaller fraction go to a dedicated travel clinic. There's a lot of nuances in travel medicine. And if my personal bias is, if you aren't sort of a dedicated travel clinic set up to kind of handle those nuances and deal with a lot of the common pitfalls, it can be really hard to do travel medicine well if you're not a dedicated travel clinic. So, naturally we see more errors if it's not a travel clinic, because, you're not as used to dealing with some of these problems, or you're trying to address the travel in the middle of a 20-minute visit where you're also addressing hypertension and diabetes. And so it's really hard to do that well. And then, outside of travel clinics, the services that you have available might be limited. And we'll talk a little bit about some of the vaccines, which, aren't always on hand. And there's a lot of international travel. This is a map that I always like to show. And I always like to say the next infectious disease outbreak is just a plane ride away, which turns out is, especially apparent. This is an old slide kind of going through a lot of the recent travel related concerns, novel and emerging diseases, which used to feel very sort of far away and not all that scary. But of course, with COVID-19, That's really sort of demonstrated how important travel is and being aware of who's traveling. So not only is it really sort of demonstrating how meaningful travel is in terms of emerging infectious diseases, but it's also greatly affected travel clinics as a whole. A precipitous drop in travel in 2020. Some of these statistics, looking at changes in TSA screening and some other major international airports, just a fraction of what they normally are. And now we're seeing travel really rebounding and returning, but there's new and changing challenges that can be really hard to navigate if you're not sort of used to navigating these types of travel questions. So there's a lot of new COVID testing requirement, which I'm certainly happy to answer questions on, and I'll address that a little bit, but I won't go into that too much because it's changing so much. But basically, a lot of what we currently spend time on in a travel visit is sort of sorting out the COVID rules and helping patients with travel and with testing and documentation that they now need for COVID. And at some point, I think the COVID vaccine is going to be embedded in travel, and there's going to be certificates and things like that, like we're already dealing with yellow fever, which I'll talk about. So our travel clinic at HCMC, so my background is I'm MedPeds trained. And then we also have some other family providers or pediatric providers here. So in our clinic, we see patients of all ages, including group visits, families. A lot of the visits I do are families traveling together, since I see both adults and kids. Traditionally, that's always been in person, but we now do telephone visits with, this era of telemedicine spearheaded by COVID as well. We have providers like myself who are ID trained, who are also the go-tos for post-travel related infection concerns. But then a lot of our other providers are just have extra training or expertise in travel medicine, but who aren't ID specialists. So we have a mix of both. We have a dedicated clinic staff where we have our own specific RN and MA, and then the providers are all dedicated travel providers. We have a specialty pharmacy partner here, which can be very important with having some of the less common medications on hand, like pediatric Malarone and things that I'll talk about. And then, a big focus is vaccines, which I'll talk about, and then travel-related medications, including the yellow fever vaccine, which I'll get into. And then because HCMC, we do our own COVID PCR testing on site. We also partner with our molecular lab. And so we do COVID testing, PCR testing for travelers. And we have priority in our lab so that we usually have a same day or at least a 24-hour turnaround time. And then, I've got the number here. People can jot that down, or I'm happy to share that again later or share these slides. But we do have a backline that providers and clinic staff can reach us, which is often very handy if you have a last minute traveler or you have big families traveling and you're trying to coordinate them getting into our clinic. This number is any other clinic is welcome to use that to get patients our way. So I mentioned that often travelers go to primary care clinics instead of a travel clinic. And so if you're, the primary care clinic seeing patients, some primary care docs do have an interest and some expertise in travel medicine and have some comfort level or maybe have some resources, but not everybody does. And so, like I said, my personal bias is that I think travelers should be seen in a dedicated travel clinic just because we have more resources and time sort of set up for that. So whenever possible, referring patients to a travel clinic. If you're able to do that and that's your preference and the patient's preference, some things that you can do to sort of make life a little easier and smoother for the patient and for the travel clinic is checking to make sure their routine immunizations are up to date. And I'll get back to that, but we really do look at that closely. If somebody needs a live virus vaccine, And particularly this comes up in pediatrics, but sometimes in adults too. It's best to delay those if they're coming to travel clinic, because if they need another live virus vaccine like yellow fever, you need to give those vaccines on the same day or separated by 28 days. Ideally, to make sure that the second vaccine is as effective as it can be. And that's a common pitfall that we run into where travelers come to us having just gotten, a varicella or MMR or something within the last 4 weeks, and then they need yellow fever, and then we can't give it or have to delay it and bring the traveler back because of that timing with the live virus vaccines. So if you think yellow fever is a possibility, wait, and we can do that here along with the yellow fever vaccine if needed. And then a lot of our patients, especially if their vaccine history isn't known. For instance, they're immigrant born overseas. A lot of times we just don't know what vaccines they've had in the past. And so it's often very helpful to check titers for hepatitis A, hepatitis B, MMR, varicella. Because if we see a traveler and we don't know their status and they don't know their status, then we're going to check titers, and then there's a delay. And so if you check titers, then we have that available by the time they come to us, and we can work off of that. And what if the travel clinic referral isn't possible? There's not time, the patient doesn't want to come. You can always call, and we're happy to help. We do telephone consults. We have a travel medicine provider on our Am I On call schedule for, other clinics at HCMC to use. And personally, I'm always happy to take calls from other clinics too, if they're not quite sure what to do. And then consult your resources. And I'll show that on the next slide. I do see a question in the chat here asking about wait time, which is a great question. A lot of that depends a little bit on the time of year and then also the type of traveler. So right now, summer is traditionally our busy season. So right now we're booked out at least a week or two for in-person visits. We have telephone visits usually available, that same week. Where we typically run into the biggest problem getting patients in, especially during our busy season, is when people are leaving within, a day or two. That can be really hard to do because we are pretty busy for visits within a couple days. And then what can be a little bit trickier is big families. We can usually squeeze in a traveler or two last minute, but squeezing in a family of 4, 6, 8, sometimes we even get families of 10, 12, which, we have to split up anyways. But if it's a big family or there's a lot of kids, sometimes those are booked, 2 weeks or more out. So it's really quite variable. Our preference is to see patients as soon as they know they're traveling. And, the earlier, the better. And some of this stuff that needs to wait till closer to their travel time, like the COVID testing, which usually needs to be within 72 to 96 hours of departure or arrival. We would prefer to see them way ahead of time and then make later arrangements for them to come back to do the COVID test closer to their travel date. So nothing is too soon, I would say, for a travel visit. And the wait time for the appointment starts to get dicier the sooner the patients are leaving. And so sometimes if that travel clinic referral is not possible, that's where doing a phone consultation can be very helpful, and we can provide advice to the provider seeing them in clinic. Like I said, I'm happy to share these slides. The CDC travel website is where a lot of people are familiar with and where they go. But there's a couple of other really nice websites too. This Global Trav EpiNet is a really nice one. And then headinghomehealthy.org, they have a lot of nice handouts and some helpful things. Shoreland Travix is what we use, and that's a subscription service that you do have to pay for. It's usually a couple $1,000 a year. So it makes a lot of sense. Most travel clinics have a subscription to something like Travax. But a lot of primary care clinics don't, because it may not be worth the expense. And then there's a lot of textbooks. CDC Yellow Book is probably the most helpful, I think, and a lot of the tables I show later come directly from that. You can access the entire CDC Yellow Book online on the CDC website, so you don't actually have to have the hard copy. You can just access it online, and that's where I would direct most people to start. So what do we do in the pre-travel consultation? There's actually a lot to it, and a lot of it is talking. And a lot of the nuances come in when we're assessing risk, which I'll talk about. So assessing risk is a big part. Counseling on chronic medical conditions, and then counseling on travel-related issues, and then prescribing travel-related medications, and then vaccines. And then actually I should update this slide and say COVID testing, because that's a lot of it now too. So what constitutes risk for patients? So there's a lot of different things. Sometimes it's a risky travel because of patient-related risks. Sometimes it's related to the trip itself. Sometimes it's both. So age, lots of chronic medical problems, including immunocompromise, lots of chronic medications, allergies, especially like severe food allergies is something that always makes me a little bit nervous. Pregnant travelers, we see a lot of pregnant travelers, a lot of pediatric travelers, elderly travelers. Those are all things that, that can make travel very risky if the patient is high risk for travel. And then a lot of it is trip specific. So how soon are you leaving? How long are you staying? A lot of the families or patients that we see are going home for months. And so a longer trip is obviously a little bit riskier than a shorter trip. Where exactly they're going, high risk destinations in general, or, very rural, remote locations being higher risk than it being in an urban city with a lot more resources. Why are you traveling? Someone taking a very expensive, all-inclusive trip with a guide is perhaps less risky than someone backpacking across Asia, or going home to visit friends and relatives. High-end lodging versus more sort of rural, remote lodging. High-risk foods, what your transportation is like, what your specific activities are. We actually go into all of this sometimes in great detail when we're talking with travelers, because it helps guide some of what we recommend, which I'll go through. And then I just want to briefly mention some of these special travel populations that I've already alluded to. Visiting friends and relatives, or VFR travelers, we see a lot of at Hennepin just based on our patient population, having a lot of immigrants here that we take care of at Hennepin. And so this is a travel population that I'm really interested in, and that can be more complicated. It refers to immigrants who are distinct from the majority population in their current country of residence, who are then returning home to visit friends or relatives. So typically that's going from a high income country to a low income country, like, US back to Somalia, for instance, which was the patients I just finished with. Most commonly to sub-Saharan Africa, but that can look in a lot of different ways depending on where patients are coming from and what your patient population is like. And it's always remarkable to me, there's often quite a length of time between when patients arrived in the United States and when they're coming back home. Most often it's at least 4 years. I've seen patients who, this is their first trip home in 20 years. And so that really does change their risk, waning malaria immunity for one, but also increasing their risk for traveler's diarrhea. I always tell immigrants that they now have American stomachs and they need to be more careful. So really kind of advising VFR travelers that, you now are at risk for some of these problems where you maybe didn't think of them when you were living there full time in the past. And then a lot of times, especially with immigrants who haven't been home in quite some time, often they've now had children, here in the United States. And so not only are they traveling home themselves, but they're also bringing their US born children who have maybe never been to that part of the world. So they're often younger and they have risks that are similar, but also slightly different than the first generation of travelers. So that can make for a very complicated travel visit. VFR travelers are at a lot higher risk for infection because they have increased exposure to pathogens, maybe because they're in more remote rural areas, they've got more close contact with the local population, they might be consuming higher risk foods and beverages, although I often see that balanced with a lot more home cooked meals as opposed to restaurants where, tourist travel might be more at risk for. But they're also often less likely to seek pre-travel advice. I mentioned that only 40% of travelers seek it to begin with, but when you look at just VFR travelers, that drops to 16%. So they're less likely to get travel vaccinations. They're less likely to take malaria chemoprophylaxis. It might be more last minute travel, family emergency or something where they have less prep time for their travel. And then, as I mentioned already, often they're going for many months as opposed to, a week or two. And then in the interest of time, I'm not going to spend too much on some of the other special travel populations. But understandably, if you have an immunocompromised traveler, and we are seeing more and more immunocompromised patients travel, we have a really big HIV clinic here at Hennepin, and a lot of our HIV patients travel. And then we also have a kidney transplant program here, a lot of whom are immigrants. So we actually see a lot of patients post-transplant who now want to travel home. And then, as more and more patients are on steroids or biologic agents for rheumatological disease, sometimes we have cancer patients traveling. So a lot more immunocompromised patients traveling. And that really requires, I think, a specialized travel visit because, there's sometimes more issues with what vaccines they can receive, which travel-related medications are safe and might interact with their chronic medications, and then sort of extra counseling about how they're more susceptible to infection. I've had to do all sorts of things like I've started a list of where the dialysis centers are in other countries, because sometimes I have patients who are on dialysis who are then traveling to Africa. And, so trying to arrange dialysis and counsel a patient on how to find dialysis in Uganda or Kenya, that I've had to do all of those things. And that's very time consuming and very challenging. So the sooner the better, certainly for immunocompromised travelers for travel clinic. Pediatric travelers, we see a lot of those too. And they're at high risk sometimes because they haven't finished all their routine vaccines because they're not of age yet. Sometimes they're too young for some of the recommended vaccines, like typhoid fever, for example. A lot of our travel-related medicines, like malaria medicines, only come in pill form. And so we do a lot of counseling with parents as to, how to crush and administer pill medications every day to young children. They're at increased risk of traveler's diarrhea and perhaps at increased risk of dehydration. So, we spend a lot of time on that. And, as we go through some of the other counseling points, I'll highlight some of the pediatric travel stuff. But really, you want someone kind of used to working through some of these issues with parents with young kids traveling. And then pregnant travelers, a lot of our VFR patients are pregnant, traveling back home. And so making sure that the patients have communicated with their OB. I have occasionally told pregnant travelers that I don't recommend they travel if there's issues with their destination or if they're high risk from an OB standpoint. But it does complicate things in terms of what medicines they can take, what vaccines they can get, unique and higher risk pathogens. And then some of these similar considerations come in when it's a traveler who's still breastfeeding. A lot of those same issues are at hand. So this is a more complicated traveler. So getting back to some of what we counsel on, we talk a lot about chronic conditions, and often that's notifying their PCP or other specialists. For example, whenever we have one of our transplant patients, I always I always communicate with the transplant pharmacist and their transplant coordinator to make sure that the transplant program is aware that they're traveling, and sometimes to help get a full supply of their immunosuppressant medications for travel. Because it's really important to have a full supply of chronic medications, especially if it's a medication that is maybe not available in the country where they're going. So for long trips, that can be a little bit complicated and time consuming. I do often provide medication letters, especially if it's controlled substances. A lot of countries have rules, especially a lot of the Asian countries, about what medicines you're actually allowed to bring into the country. And there are some letters and requirements that come along with that. So especially kids on ADHD meds, or adult patients on narcotics, things like that require a little bit of paperwork. I mentioned food allergies already. That's something I talk a lot about, and making sure that people have up-to-date EpiPens. Those typically we don't prescribe chronic medications, but like things like EpiPens or albuterol inhalers are things that that we will prescribe. And then a lot of it is anticipation or planning for potential problems. So, a traveler who's on Coumadin, for example, how's their malaria medicine going to affect their INR? And if they need to check their INR, where do they go? And, things like that. Diabetic travelers, especially ones on insulin, sometimes that requires a lot of discussion. Sometimes we're looking into and giving recommendations for where to get medical care at their destination. And then also going into what the options are for overseas medical insurance or evacuation insurance. And these are all things that we have resources and information for, that we go over with travelers. This is a list of some of the travel related issues that we talk about in BOLD, or the ones that I talk about pretty much every visit in some way, shape, or form. There's always some discussion about food and water safety. I always go through insect avoidance, sometimes malaria prophylaxis, but almost any of the international destinations have something, whether it be dengue or chikungunya, or, so even if they don't need malaria prophylaxis, talking about insect avoidance is almost always relevant. Animal bites is something that I always talk about, especially with pediatric travelers, because there's a lot more rabies in other parts of the world. And then kids who are born and raised in the US are used to seeing, safer, friendlier animals, that are pets out on the street, as opposed to strays. And so I spend a lot of time actually counseling kids about animals and why you shouldn't pet animals that you see on your travel, and talking to parents about, making sure that if anyone does get a bite, that they go for rabies shots, and really spending a lot of time on that. Road safety is another thing that I always talk about and bring up. A traffic accident is actually the #1 cause of mortality when it comes to travel. And so, making sure, again, especially with pediatric travelers, talking about, have you thought about what you're going to do for a car seat, and things like that, that can be complicated discussions. Another thing that, assuming they've got a longish plane ride to get there, another thing that I always highlight, especially with adults, or especially with young women who are on birth control or pregnant, is really talking about DVT risk and prevention. Obviously, if they're taking a shorter trip, flying to, to the Caribbean or something, I don't necessarily go as much into this, but, long flights to Africa, et cetera, this is really important. And then the rest of this list here may or may not be relevant. Anyone who's doing high altitude trekking or going to a high altitude destination, we talk a lot about that. Seasickness, motion sickness, jet lag, STDs and other high risk behaviors. It's a decently high percentage of patients have unplanned sexual encounters when traveling. And so this is, something that we always mention too. Cruise ships, mass gatherings, there's sort of unique things to discuss. So this isn't something we always go into, but, does come up depending on the traveler and the trip. So in terms of medications, we have sort of a standard list that we provide for patients of over-the-counter medicines that we recommend. You can see the list here. Some of those we do prescribe, but a lot of it is just sort of a list of, check your medicine cabinet or go to the pharmacy. A lot of people have some sort of disruption in their bowels when traveling, acid reflux, sometimes allergies at destinations, something with, something that kicks off a different type of pollen or something like that. So making sure people have decongestants and allergy medicines, having a little bit of a medical kit so that you don't have to scramble to try to find something if you have a problem while traveling. And then in terms of prescription medications, we've got preventative medicines and then also self-treatment medications. And some of these I do go through a little bit more on some of the next slides. But malaria chemoprophylaxis is a big one. And I'll talk a little bit more about that. Prescribing medications to help with altitude sickness, seasickness, HIV, either post-exposure prophylaxis or sometimes pre-exposure prophylaxis. So that is something that we often do for travelers. And then for self-treatment, we'll talk a little bit about self-treatment for travelers' diarrhea. And then, especially women who are going to be taking an antibiotic like doxycycline for malaria chemoprophylaxis, I'll often talk to them about self-treatment of yeast infections, self-treatment, for instance, patients who have recurrent UTI issues, they'll often go in hand with something for treatment there. And then, sometimes travelers aren't able or aren't willing to do malaria chemoprophylaxis, prevention of malaria. And so if they won't do prevention, then I always make sure that they at least have a round of something on hand for symptom-based treatment. So, you have a fever, you need to get checked out, but while you're getting checked out, start treatment for malaria and here's a prescription so that they don't have to worry about getting to medical care. Or the other thing that I worry about in certain destinations is, they could go to a pharmacy and they could get something for malaria on their own, but how do they know that it's a trustworthy pharmacy, and how do they know that it's not a counterfeit or expired medication? Because that is a big problem in other parts of the world. So having travelers go to the country with prescriptions in hand is always preferred. Now, since we're short on time, I'm not going to go too much into the malaria chemoprophylaxis, but I'm happy to provide these slides. Atovaquone proguanil or Malarone is typically my go-to because it's the one you take for the shortest amount of time, and it's the safest medicine with really the lowest risk of side effects. Problems are that with poor renal function, it's an issue. It hasn't been studied in pregnancy, so it's also not preferred in pregnancy. And it can be expensive, and it is a daily medication, which can be difficult for children. Mefloquine here on this side has fallen out of favor because even though it's once a week, which is very convenient, especially with children, it now has a black box warning on it in the United States. You shouldn't give it to anyone with a history of seizures or anyone with a mental health history because it can cause some potentially prolonged neuropsychiatric symptoms. And so I do still prescribe it. It is the only medicine in chloroquine resistant parts of the world for malaria. It's the only class B medicine in pregnancy. So I do give it to pregnant women or to travelers, pediatric travelers, long stay travelers. But you do need to counsel and be aware of some of the neuropsychiatric concerns, although most people just have vivid dreams and that's it. Doxycycline is the cheapest. And so sometimes we use it for that reason, but it also is once a day and it has side effects and you have to take it for a long time after return. So it kind of, other than being cheap, you sort of don't get any of the other benefits that you can get with Malarone or Mefloquine. And I'm going to skip over this slide because it's really not that often that we have people traveling to chloroquine susceptible parts of the world. And primaquine and tafenoquine, which is the newest malaria medicine, I pretty much never prescribe, either because it's not relevant or because there's issues with G6PD testing needed, or availability. So I'm gonna skip over those because I can't even remember the last time I prescribed chloroquine, and I've actually never prescribed tafenoquine. I want to talk about traveler's diarrhea just real briefly, and I'm not going to go through all of these slides, but this is the most common condition reported by travelers, and it varies quite a bit depending on your destination. And I have things sort of broken into low, intermediate, and high risk. And there are certain things that put people at higher risk. I already mentioned children, but anyone on acid suppressive medications, and people who are real adventurous eaters, low cost accommodations, cruise ships. And people, classically think of it as, consuming fecally contaminated food or water, which is a big part of it. But a lot of it is actually also hand hygiene practices, either for the traveler or for the people at the destination. So sometimes it's not what you're eating, it's what's on your hands when you're eating, or what was on the hands of the people preparing your food. Most traveler's diarrhea is caused by bacteria, but viral and protozoan pathogens are also implicated. And symptoms I'm not going to talk about too much, but shorter incubation and duration for bacteria and viral, whereas the more prolonged chronic diarrheas are more likely to be protozoan parasites or something outside of the normal realm. What we worry most about and what I counsel people most about is dysentery or traveler's diarrhea, where you have fever and bloody stool. These are the travelers where antibiotics are most warranted and appropriate. And you can see, the classic or most common causes of dysentery for travelers. Traveler's diarrhea has changed a lot over the years, sort of how we counsel and prevent or advise on it. Way back when, there used to even be prophylaxis for traveler's diarrhea. What we're seeing more and more of, and something that concerns me quite a bit, is there's a lot of really good and kind of horrifying data that people who travel and take an antibiotic while traveling have really, really high rates of colonization with multi-drug resistant pathogens like ESBL, E. coli's, and things like that. And so really what we accentuate these days is when to take the antibiotic, and really only taking it for very severe symptoms. So I tell patients blood, high fevers, or you're incapacitated and can't leave the bathroom or your house or hotel room. Anything mild or moderate, not to take an antibiotic, and to really save it for those really severe symptoms. One, because the milder symptoms are more likely to resolve on their own. And the mild to moderate symptoms are less likely to be a real invasive bacterial pathogen like a Shigella or Campylobacter. Sorry, I skipped over the part, but azithromycin is usually my go-to because of drug resistance in other parts of the world, and fluoroquinolones have really fallen out of favor, in part because of resistance, but also just because of all the side effect issues with fluoroquinolones. I know we're at 1:05, so I'm gonna skip over this because I talked a little bit about how we already look at routine vaccines. And I'm happy to keep going since I know I got a later start, and just briefly mention the travel vaccines. I just have a couple more slides on them.
Yep, that's great. You can keep going. That's just fine.
Because I know you're recording anyways, so yeah, people who have to break off can hopefully watch it later. In terms of the travel specific vaccines, hepatitis A is a really important one because it is so common, and the older you are when you get hepatitis A, the sicker you are. And here in the US, it's becoming less and less of an of an issue for vaccination because it's part of our childhood series since 2008, roughly. So a lot of the pediatric travelers I see are already up to date on this, but adult travelers, not so much. And so particularly for adults, making sure that they've had hepatitis A vaccine. And then it's now recommended that we give it early. So normally for kids, we start at 12 months for Hep A vaccine, but you can give it as early as 6 months, but then it doesn't count towards their routine series. So sometimes I'm giving this early to pediatric travelers too. Typhoid is another one that we give a lot of. There's an inactive vaccine, which is quick and easy, but doesn't protect you for as long. And then there's an oral vaccine, which they're actually not making right now because of the decreased demand with travel during the COVID pandemic. So even if I wanted to give someone an oral typhoid, I can't right now, and I'm not quite sure when that'll come back. But typhoid, the oral vaccine, it's a live virus vaccine, but it does protect you for longer. Polio is something where some countries still require a booster for this, and you actually have to document it on the yellow card, which I'll talk about in a moment. Most of these countries are parts of Africa where they've recently picked up vaccine related strains of polio because they still use oral polio vaccine, or, you know, obviously some of the rare parts of the world like Afghanistan where there still is some circulating polio. Also Hajj travelers, you know, are required to get polio, you know, for the mass gathering aspect. So sometimes we're giving out polio vaccine for adults. Rabies is something that we counsel on and sometimes do vaccinate, do a pre-exposure vaccination for, which can be really beneficial for travelers, long stay travelers, high risk travelers, people going to really remote areas, because it takes away the need for the immunoglobulin and you need fewer post-exposure vaccines. So it can really be quite beneficial for certain travelers. There's also now a US cholera vaccine for adults, but that's also not being made right now because of the pandemic. So I'm gonna skip over that. And it's something that I hardly ever use anyways, because it's really mainly recommended for people going into really high risk cholera areas like, you know, aid workers and people, you know, going to actual cholera outbreak sites and things like that. Meningococcal vaccines is something that we do a fair amount of. It's required for the Hajj, like polio is, and then it's also recommended for travelers to the meningitis belt of Africa, which you can see on the slide here. And so, and there, it is recommended that you booster every 5 years, more frequently for younger children. So people who travel to these regions of the world a lot, you know, sometimes we're giving them regular boosters of meningococcal vaccines. Japanese encephalitis is, I think, probably the trickiest travel vaccine, in part because we really just don't know a lot about the true incidence of infection. So this is a mosquito-borne daytime biting mosquito. And you can see the map there for, you know, it's basically kind of widespread throughout Asia. And we don't really know how common infection is. I think of Japanese encephalitis very similarly to West Nile, which, you know, here in Minnesota, we're a little bit more familiar with. So there's probably a lot more infection than we realize because some of it is nonspecific and only few people develop really bad neurological sequelae. And the life cycle and sort of the risk is very similar for West Nile. So we don't really know how common this is in travelers or people who live in the region. It's rarely been reported, but it's also not routinely looked for, especially for travelers with mild symptoms. So we don't really know how common and how important it is. We do know that a small proportion of people who get Japanese encephalitis do have some really serious long-term neurological sequelae. So if you do get yellow fever and have a really bad case, it's a really bad thing. And there is a good vaccine for it. The problem is it's a very expensive vaccine. It's a 2-dose series and it's about $400 or $500 a shot if it's not covered by insurance. And so traditionally the recommendation had been for people with prolonged stays in very rural areas, but there's a lot more data now that shows that even people in urban areas are getting are at risk for Japanese encephalitis. So this is a really tricky one. There's a lot of nuance and a lot of discussion as to like, well, who should we really be giving a Japanese encephalitis vaccine to? And so that's definitely something best done at travel clinic, and most other clinics don't even carry it. And if I'm going to give it, I typically have travelers check with their insurance first, because it's a lot easier to decide to get the vaccine if you know it's covered than if you know you are going to have to pay $1,000 for it. So, and then yellow fever vaccine is the most specialized for travel clinics. So you actually have to be a yellow fever certified clinic in order to give the vaccine. There's a process you have to go through your state health department and registering through the CDC. So you actually have to be approved and sort of licensed to give yellow fever. The reason for that, I think two reasons. One is it is a vaccine that is required for entry for certain countries. So this changes all the time, but some countries you actually have to have a yellow fever vaccine for entry, and it has to be documented on, this is the yellow card or the International Certificate of Vaccine or Prophylaxis, the ICVP. So you have to document it in a specific way. There's a stamp that's specific to a provider and to the specific travel clinic. So there's a lot of rules and regulations for being able to administer yellow fever vaccine because of the WHO international requirement for vaccination for some areas. And then part of the requirement also comes along with some of the very rare but potentially serious side effects. It's a live virus vaccine, so you can get a viscerotropic vaccine reaction where you basically get yellow fever from the vaccine itself. And then a little bit more commonly, but still pretty rare, there's neurotropic disease where you get basically an encephalitis from the vaccine. People usually recover from the encephalitis, but you know, things with the brain are always scary. Whereas the viscerotropic side effect is actually, the fatality rate is about, you know, up to 50%, 20 to 50%. So that's also part of why this is a little bit more regulated, because there are some scary side effects to go through. It's only for age 9 months and above, and there's a precaution above age 60 because these rare side effects get slightly more common, but are still very rare. And so the good thing is that it's now thought to be lifelong protection. So you used to have to get a booster every 10 years. Now, as long as your immune system is normal, many patients only need a once in a lifetime shot, which makes it, you know, a little friendlier. And the other thing that I'll just say briefly about this with the licensing is not only does your clinic need to be licensed, but everyone at your clinic involved in giving the vaccine also has to go through specific training, through online training through the CDC. So like your MAs, your nurses, they all have to be trained and so that they're knowledgeable about these side effects and these issues and the yellow card and all that. So there's a lot of sort of extra hoops that need to be jumped through, which is why not every clinic is able to give yellow fever vaccine, even if they wanted to. So I'm going to stop here. I'm certainly happy to give a talk again in the future, because really illnesses and return travelers are a whole talk in on themselves. The only point I want to make is that febrile travelers who have been to a malaria area, that's considered a medical emergency because falciparum malaria can be rapidly fatal within a matter of hours to days. So febrile travelers, you always want to know if they've been to a malaria area, and you always want to consult with a ID doc or travel person, because that is a medical emergency. So I always like to throw in that little tidbit. So I'll stop there, and I'm happy to take other questions that people might have. And I know that was a whirlwind, but I hope that was useful.
Yes, it was very good.